Welcome to The Deep Dive, the show where we really get into complex topics, cut through all the noise, and give you the most vital, most fascinating insights. Today we're tackling a subject that affects, well, hundreds of millions globally, yet it remains deeply misunderstood by so many. Did you know that morbid obesity is now the second leading cause of preventable death in the United States, right after smoking? That's a truly startling fact, isn't it? And one that just highlights the immense societal and personal impact of this condition. Okay, let's unpack this. Today we're taking a really deep dive into the complex world of morbid obesity and the transformative role of bariatric surgery. Our mission for you, our curious listener, is to not just scratch the surface, but to truly master this information, from the intricate science behind why our bodies gain and retain weight, to the groundbreaking surgical procedures that offer profound solutions and their very real-world impact on human lives. We're drawing exclusively from a leading medical text, the SABISTON Textbook of Surgery, 21st edition, to give you the kind of well-informed perspective that feels like a shortcut to expertise, arming you with knowledge even many professionals might not fully grasp at this level.
Yeah, and what's fascinating here is that while the sheer numbers are staggering, the story of obesity is also deeply, profoundly personal for millions. And for too long, it wasn't even recognized as a disease, which had, direct and devastating impacts on how it was treated, how research was funded, and crucially, how it was compensated by insurance. That was huge. This deep dive isn't just about statistics or surgical techniques, it's about understanding a condition that shapes the lives of countless individuals, exploring the scientific breakthroughs in treating it, and grappling with the life-altering choices individuals face. We'll explore why conventional methods often fail, and how surgery has emerged as an approach with, well, the text calls it absolute superiority in treatment. And that's not just for weight loss, but for reversing debilitating medical problems, significantly improving and extending lives, and fundamentally changing the patient's biological set point. It's a whole different ballgame.
Okay, so let's start by defining what we're actually talking about, because the understanding of morbid obesity has really shifted over time. It was a critical turning point when the American Medical Association, the AMA, officially recognized obesity as a disease back in 2013. That wasn't just a semantic change, was it? It had really profound implications. Then, in 2014, the AMA went further, approving a resolution advocating for a full continuum of care for evidence-based obesity treatments and explicitly including surgical interventions. So why was this recognition so incredibly significant for patients and for the entire medical community?
Oh, that recognition was absolutely monumental. Historically, morbid obesity was, well, vaguely defined, perhaps as being 100 pounds above ideal body weight or twice ideal body weight. It just lacked precision, and that made it incredibly hard to categorize, to study, and critically, to get insurance compensation for treatment. It was a real barrier. Without a clear medical classification, it was often dismissed as, a lifestyle choice or a lack of willpower rather than what it is, a complex chronic disease. The AMA's recognition, and especially that 2014 resolution, gave it the legitimacy it desperately needed. It shifted the perception from a personal failing to a medical condition requiring a comprehensive, often complex treatment approach, just like diabetes or heart disease. This opened doors for research funding, standardized treatment protocols, and probably most importantly, improved access to care for patients. So today, the current internationally accepted standard for defining morbid obesity is a body mass index, or BMI, of 40 km/h. And just for clarity, BMI is a simple calculation, a person's weight in kilograms divided by the square of their height in meters. The National Institutes of Health, the NIH, actually prefers the term severe obesity, which you'll see used interchangeably with morbid obesity in our source material, but essentially they refer to the same clinical threshold.
Right. And having that single, clear, internationally accepted definition, like the BMI of 40 kilograms, truly has revolutionized how this condition is studied, how it's treated, and how research is conducted globally. It's like everyone's finally speaking the same language.
Exactly. It provides that common language for medical professionals, researchers, policymakers, allowing for much more unified and effective strategies against this epidemic.
What really stands out when you look at the sheer scale of this problem is its prevalence. I mean, it's staggering. In the U.S., nearly 40% of adults are now classified as obese. And the prevalence among adolescents has alarmingly increased to nearly 1 in 5. Think about that. Almost half of American adults and a significant portion of our youth are living with obesity.
And to give you some historical context, the percentage of obese adults, so that's a BMI greater than 30, in the United States, increased by a staggering 16 percentage points just from 1980 to 2000, and then it kept climbing, increasing by another 9 percentage points from 2000 to 2016. This isn't some static problem that's plateauing, it's an escalating one that continues to challenge our healthcare systems and, really, our societal well-being.
And it's not affecting everyone equally across the board, is it? Which speaks volumes about the complex social determinants of health. We see significant demographic disparities in the U.S. Non-Hispanic Asians, for example, have significantly lower rates of obesity, around 13%, compared to all other racial and non-Hispanic origin groups. Non-Hispanic whites have a prevalence of around 38%, which is notably lower than both non-Hispanic black adults at nearly 47%, and Hispanic adults also at 47%. And diving deeper into specific groups, Hispanic men show a greater prevalence of obesity compared to non-Hispanic Asian and non-Hispanic black men. These disparities really underscore that the fight against obesity isn't just a medical one, it's also a social justice issue.
Absolutely. And if you expand that view to the global picture, the trend of increasing obesity in children and adolescents, so aged 5 to 19, has been observed in most regions worldwide from 1975 to 2016. Now, while the rate of increase in BMI has actually decreased in most high-income countries since 2000, it still remains at a high level. Worryingly, the rate of BMI increase has accelerated in East, South, and Southeast Asia. It's projected there to surpass the number of moderate to severely underweight children by as early as 2022. That signals a massive shift in global health burdens, moving from undernutrition to overnutrition.
And it's not just the U.S. leading the pack anymore. Yeah, several countries, particularly island nations in the Pacific, like Nauru, the Cook Islands, Palau, Niue, and American Samoa, have actually surpassed the United States in the prevalence of obesity, with some reporting rates well over 50%. Globally, entire regions like Polynesia, Micronesia, the Middle East, and North Africa all have obesity prevalence rates of 20% or more. This just illustrates the truly global nature of this epidemic.
And zooming back in on the U.S. specifically, the prevalence of morbidly obese adults, those with a BMI greater than 40, has risen to 6.3% of the entire adult population. And as you mentioned right at the top, this positions morbid obesity as the second leading cause of preventable death in the United States. That's a stark reality. It makes it second only to smoking in terms of preventable factors, driving up healthcare costs and diminishing quality of life.
So what does this all mean for individuals? I mean, it's a sobering thought to realize that a 40-year-old morbidly obese man faces a 12.4% reduction in life expectancy. That translates to a loss of 9.1 years of life compared to a normal-sized man. This isn't just about weight, is it? It's about years taken away, opportunities lost, and a significant decrease in overall health span.
And the economic burden is equally staggering. The cost of care directly related to obesity may be as high as 9% of annual medical expenditures in the U.S., totaling an estimated $147 billion per year. I mean, to put that in perspective, that's more than the entire budget for many federal agencies combined. It's a massive drain on resources that could otherwise be allocated to other critical public health initiatives.
So the critical takeaway here, really getting to the core of it, is that the sheer scale and unequal distribution of this epidemic reveal a deeply intricate challenge. It's not just a health crisis, but a societal one, exposing disparities that demand tailored, equitable solutions, not just blanket approaches. The source points out something interesting. There appears to be significant population heterogeneity between BMI and mortality, which is attenuated by increasing age. Meaning, while higher BMI is always a risk, its impact on mortality can vary across different demographics, becoming less pronounced in older age groups compared to younger ones.
Right. Ultimately, age, gender, race, and income level all play a complex, interconnected role in the development of obesity and obesity-related mortality. It illustrates that this isn't a simple equation of calories in, calories out. It's far more complex.
Moving beyond the sheer scale of the problem, let's challenge a common misconception right off the bat, that obesity is simply a matter of willpower or just eating too much. Our source material makes it abundantly clear that the pathophysiology of severe obesity is multifactorial. It's a complex tapestry woven from genetics, environment, and biology.
Indeed. At its very basis, there's a significant genetic predisposition. The text notes a clear familial pattern, highlighting that it's rare for a single family member to have severe obesity. If one family member has severe obesity, it's highly likely that others do or will. This isn't just about what's on your plate, it's often in your genes, establishing a baseline susceptibility that environmental factors then interact with.
So we often hear about genetics and diet, but have scientists actually pinpointed specific genes that play a role in severe obesity? What have they found when they've actually been able to unpack some of that genetic code, getting into the weeds a bit here?
Absolutely. They've identified several. One notable example is the FTO gene, which stands for fat mass and obesity related. This gene plays a crucial role in controlling fundamental processes like feeding behavior and overall energy expenditure. Another is the MC4R deficiency gene, or melanocortin-4 receptor, which has been directly associated with obesity, increased fat mass, and insulin resistance. Now, it's important to understand that single gene mutations causing obesity are actually quite rare. They typically express themselves during early childhood, often leading to what's termed monogenic obesity. However, the MC4R gene is considered the most common single-gene etiology for severe obesity. It works by inducing appetite suppression or anorexigenic effects on the hypothalamus, a key area in the brain that regulates energy homeostasis. Recent studies even suggest that the cilium of MC4R neurons in the hypothalamus is the most common pathway underlying the genetic causes of human obesity. Our source, in Table 48.1, details these gene mutations and their profound effects. It shows just how specific and impactful these genetic predispositions can be.
It's incredible to think that our tiny internal residents, the bacteria within our gut, our microbiome, might also play an essential, yet often overlooked, role in this complex picture of metabolism in the immune system. We're essentially walking ecosystems.
It's a fascinating theory, and there's compelling evidence. Consider a mouse study where simply giving subtherapeutic antibiotic treatment for 4 weeks led to increased adiposity and elevated plasma levels of insulin, leptin, and triglycerides when those mice were later fed a high-fat diet. But crucially, this predisposition to obesity was transferable to other mice when the low-dose penicillin-selected gut bacteria were transferred to germ-free hosts. This strongly suggests that it was the action of the altered gut bacteria, not just the antibiotics themselves, that caused the obesity. This opens up entirely new avenues of understanding, doesn't it?
It really does.
And this isn't just about mice. It connects to human lifestyle, too. Recent studies have shown that disruptions to the gut microbiome's circadian rhythm, which can be caused by lifestyle differences in developed countries like shift work or jet lag, provoke the development of altered microbial communities. These altered communities, in turn, predispose the host to obesity and glucose intolerance. Furthermore, degradation of dietary flavonoids by an altered microbiome can result in diminished energy expenditure, leading to obesity. So what we eat, when we eat, even our sleep patterns, can profoundly impact our internal microbial world with significant metabolic consequences.
So it's a truly fascinating, almost speculative hypothesis. Could the current epidemic of obesity actually be linked to changes in the microbiome created by the lifestyle shifts and increased use of antibiotics in childhood, especially in people who reside in developed countries? It really makes you think about how our modern world interacts with our biology at the most fundamental level.
Definitely. And beyond genetics and the microbiome, when we look at severely obese individuals, a very clear pattern emerges. They often experience persistent hunger that isn't satiated by amounts of food that would satisfy a non-obese person. This fundamental lack of satiety, or the persistent maintenance of hunger leading to increased calorie intake, might be the single most important factor in the entire process. The theory here is that there are fundamental differences in the brain's energy set point, a kind of internal thermostat for body weight which rises, leading to increased energy intake through the modulation of the individual's appetite. It's as if their body is constantly telling them they need more fuel, even when they've had plenty.
That makes so much sense. It's all about how our brain talks to our gut and vice versa. We know that hormones, peptides, and vagal afferents, which are nerve signals to the brain, have a major influence on satiety, appetite, and overall energy intake. Let's talk about one of the key players here, ghrelin. This is often called the hunger hormone, right? And it's the only known orexigenic or appetite-stimulating gut hormone.
That's the one.
It's secreted by specific cells called PD-1 cells in the gastric fundus, part of the stomach. Ghrelin stimulates the release of various neuropeptides, like neuropeptide Y or NPY, and growth hormone from the hypothalamus, which then creates that orexigenic or increased appetite state. Think of ghrelin as your stomach's empty signal. It screams hunger.
And here's the likely why behind diet failure for so many people. Increased levels of ghrelin produce increased food intake. What's really striking is that increased levels of ghrelin develop in individuals after low-calorie diets. This suggests that one powerful yet often overlooked mechanism for the failure of most diets after about 6 months is precisely this increase in the appetite hormone ghrelin. It makes it incredibly hard, almost biologically programmed, to sustain weight loss. Your body is fighting you, telling you to eat more. And building on this complex interplay, one evolving concept is that the environment actually causes heritable changes in gene function without modifying the DNA sequences themselves. This is termed gene-environment interactions affecting the epigenome. Epigenetics essentially describes how external factors can switch genes on or off or modify how they're expressed without changing the underlying DNA code. What's critical here is its significance. These epigenome changes leading to the development of obesity are actually much more common than either the rare monogenetic or syndromic forms of obesity. It highlights that our lifestyle and surroundings aren't just triggers, they can fundamentally alter how our genes behave and pass on certain metabolic tendencies.
And as a metabolic disease, morbid obesity is associated with numerous other medical problems, many of which are virtually unknown in the absence of obesity. Our source lists these out in detail in box 48.1, and it's quite a cascade of issues, fundamentally altering a patient's entire health trajectory. For example, musculoskeletal problems are incredibly frequent, affecting over 50% of patients, particularly chronic conditions like arthritis and severe degenerative joint disease.
That's right. The pulmonary system is also heavily impacted, with obstructive sleep apnea, where breathing repeatedly stops and starts being highly prevalent. It affects a staggering 35% to 94% of patients, typically over 60%. Asthma is present in more than 25%, and there's also the severe hypoventilation syndrome, where the body simply can't breathe deeply enough to get enough oxygen. The cardiovascular system suffers significantly, with hypertension in over 30% and increased risks of sudden cardiac death, myocardial infarction or heart attack, cardiomyopathy, which is a weakened heart muscle, venous stasis disease, deep venous thrombosis, pulmonary hypertension, and right-sided heart failure. It's a long list.
Then there's the metabolic fallout, which is often at the core of these issues. You have the metabolic syndrome itself, characterized by abdominal obesity, hypertension, dyslipidemia, and insulin resistance. Central body obesity, meaning a waist circumference over 35 inches for women or 40 inches for men, is a primary feature there. Type 2 diabetes affects more than 20% of severely obese individuals, alongside hyperlipidemia, hypercholesterolemia, and non-alcoholic steatotic hepatitis, or NAH, which is essentially a severe form of non-alcoholic fatty liver disease that can lead to cirrhosis.
Gastrointestinal issues are also common, with gastroesophageal reflux disease, or GERD, affecting 20% to 30% of patients, and cholelithiasis, or gallstones. Genitourinary problems include stress urinary incontinence and end-stage renal disease, often secondary to diabetes and hypertension that have damaged the kidneys over time. For women, gynecologic issues like menstrual irregularities and polycystic ovarian syndrome are frequent. And externally, skin problems like fungal infections, boils, and abscesses are often seen in skin folds. And then, shockingly, obesity has been shown to significantly increase the risk of developing at least 13 types of cancer.
13. Wow.
Yes. This is a crucial point that highlights obesity as a major public health concern beyond just cardiovascular or metabolic disease. This includes common cancers like thyroid, colon, rectum, esophagus, stomach, kidney, prostate, gallbladder, pancreas, postmenopausal breast, endometrium, ovaries, and cervix. And you might ask, how does this happen? There are several proposed mechanisms. Obesity increases chronic systemic inflammation, which is linked to esophageal adenocarcinoma, often exacerbated by chronic inflammation from GERD. Fat tissue also produces excess levels of estrogen, directly linked to an increased risk of endometrial, ovarian, and postmenopausal breast cancer. Finally, increased levels of insulin and insulin-like growth factor 1 are hypothesized to fuel the development of certain cancers, including colon, prostate, kidney, endometrial, and postmenopausal breast cancer. It's a complex, multi-pronged attack on the body.
Beyond the purely medical, our source also broadens the discussion to the often overlooked societal and psychological challenges faced by individuals with severe obesity. These are deeply personal issues that don't always show up on a medical chart, but profoundly impact daily life. Severely obese individuals frequently encounter discriminatory problems in society. Think about simple access issues. Public facilities with inadequate seating, narrow doorways, or challenging restroom facilities can make attending events or simply navigating daily life incredibly difficult, if not impossible. Travel on public transportation or by air can also be severely limited. And employment discrimination clearly exists for these individuals, impacting their economic stability and self-worth.
And these social difficulties take a significant psychological toll. The constant battle with public perception, the lack of appropriate infrastructure, combined with common co-occurring issues like low self-esteem, a frequent history of sexual or physical abuse, and this constant social discrimination. Well, it all coalesces to create a very high incidence of depression in the morbidly obese patient population. It's a hidden burden that profoundly affects their mental well-being and overall quality of life, making the condition even more challenging to manage.
Okay, so shifting gears to treatment. When we talk about treating severe obesity, we have to acknowledge a stark reality. For a very long time, medical therapy alone had extremely limited short-term success, and frankly, almost non-existent long-term success. It was a historical struggle for both patients and providers, leaving many feeling hopeless.
That's absolutely true. Once a person is severely obese, the likelihood that they will lose enough weight through dietary means alone and maintain a BMI below 35 kg Nirkana is estimated at a dismal 3% or less.
Only 3%.
3%. Think about that. A 97% chance of failure with diet alone for severe obesity. Even the NIH Consensus Conference back in 1991, decades ago, recognized that for this patient population, medical therapy had been largely unsuccessful in treating the problem. Reviews of clinical trials on lifestyle interventions for obesity prevention consistently showed that the majority were completely ineffective, and even the few that were marginally effective had an extremely small, almost negligible impact on BMI. This historical struggle really underscores the desperate need for more effective, durable interventions.
What's fascinating here is how bariatric surgery has completely changed the game. Our source describes it as one of the most remarkable stories in modern medicine. It truly represents an absolute superiority over medical therapy for the treatment of morbid obesity and its associated comorbidities. This isn't just a minor improvement, it's a paradigm shift.
The evidence is incredibly compelling and truly foundational. Multiple long-term follow-up trials comparing morbidly obese diabetics who underwent bariatric surgery with those who did not have consistently shown decreased mortality in the long term after bariatric surgery. This isn't just about weight loss, it's about life extension and profound health transformation. The data in Table 48.2 provides a clear overview of these pivotal studies, each reinforcing the surgical advantage. Let's delve into one of the most significant pieces of evidence, the Swedish Obese Subjects, or SOS study. This was the first prospective controlled trial to provide comprehensive long-term data spanning 10 to 20 years of follow-up on the effects of bariatric surgery on diabetes, cardiovascular events, cancer, and overall mortality. The study enrolled over 2,000 bariatric surgery subjects and over 2,000 matched controls who received standard medical treatment. The follow-up rate was astonishingly high at nearly 99%. At 15 years, the surgery patients had lost an average of 18% of their body weight and maintained it, whereas the control group had only a negligible 1% weight loss. This sustained weight loss and reduction in comorbid conditions in the surgical group resulted in a dramatic 29% reduction in overall mortality with an adjusted hazard ratio of 0.71. That means for every 100 people who died in the control group, only 71 died in the surgery group.
And the specific benefits identified by the SOS study are truly remarkable. The most common cause of death in the control group was cancer, with 47 deaths compared to only 29 in the surgery group. The incidence of myocardial infarction, or heart attacks, was also significantly reduced in the surgical group. And the surgery group experienced a lower number of first-time cardiovascular events overall. Most strikingly for diabetic patients, the SOS trial showed an 80% decrease in the annual mortality of diabetic individuals in the surgical weight loss group, compared to the matched control patients. 80%.
It's huge.
That's a 9% mortality rate in the surgery group versus a 28% mortality rate in the control group. These are profound differences, really laying bare the life-saving impact of surgery.
Indeed. Now, while the SOS study found improvement in all-cause mortality after 10 years, it's worth noting that the majority of procedures performed in that study were vertical banded gastroplasty, which is an older procedure. Roux-en-Y Gastric Bypass, a much more effective procedure, comprised only 13% of the operations in SOS. Since RYGB is far more effective, it's not surprising that more recent studies, like the Adams and Guidry studies, which specifically compared RYGB to medical treatment, showed convincing mortality differences as early as 3 to 5 years after surgery, much earlier than the SOS study. Similarly, the Calpapila study, which followed nearly 50,000 patients, mostly RYGB, across 5 Nordic countries, also found a reduced all-cause mortality that improved even further at 15 years. This growing body of evidence over decades paints a very clear picture.
Another important study, the Adams study, involving thousands of patients, showed a 40% reduced mortality rate overall after gastric bypass, including a 56% reduction for coronary artery disease, incredible 92% reduction for diabetes, and a 60% reduction for cancer. Just massive reductions. And the Arterburn VA study, which focused on a predominantly male population, also identified an all-cause reduction in mortality at 5 years. This study is particularly notable for showing how surgical care improved over time. The first-year mortality rate was higher in the earlier part of the 2000s compared to later, reflecting those advancements in surgical technique and postoperative care. Despite that initial higher rate, the overall mortality rate was consistently lower for surgery patients compared to the medically treated group after 5 to 14 years.
And to provide the most up-to-date picture, Adams and colleagues recently published a 12-year follow-up to their 2007 trial. This study tracked hundreds of gastric bypass patients against two control groups, matched patients who sought but didn't undergo surgery and those who never sought surgery. The findings confirm sustained improvements in both weight and comorbidity metrics, reinforcing the long-term durability of these profound benefits, as you can see clearly in Table 48.3. This isn't a short-term fix, it's a long-term, life-altering solution.
Now, a common question arises. Does this incredible long-term effect hold true for older patients who often have a higher operative mortality risk and potentially less time to see the long-term benefits?
Surprisingly, the data suggests it does. A large cohort study involving nearly 8,000 morbidly obese patients matched to an equal number of controls who didn't undergo surgery showed that long-term mortality was lower in the surgery groups for patients aged 35 and older. In fact, the highest reduction in long-term mortality was observed in men aged 55 to 74 years. This really challenges the old assumption that older age negates the benefits. However, it's worth noting a counterpoint. Younger patients, specifically those under 35, experienced a significant increase in externally caused deaths, such as accidents or suicide. This was even higher in young women. Nevertheless, this finding, while important for careful patient selection and psychological screening, doesn't negate the overall profound benefit for older patient populations.
One perception of bariatric surgery is that it might induce profound, unalterable changes in eating that negatively affect a patient's health-related quality of life, or HRQOL. However, a well-done 12-year prospective study specifically evaluated HRQOL changes after gastric bypass surgery compared to two non-surgical groups matched for similar demographics. The patients who underwent bariatric surgery had greatly improved quality of life in the physical component from before surgery. There were also significant differences between the surgery patients and both non-surgical groups for both weight-related HRQOL and overall physical HRQOL. The magnitude of improvement after 12 years after gastric bypass surgery, both from before surgery and compared to matched control groups, strongly supports the conclusion that bariatric surgery genuinely and durably improves the patient's quality of life. It's not just about living longer, but living better.
Right. While the quality of life improvements are clear, this study, along with the SOS study, identified a critical and sensitive finding: an increase in suicides and self-harm in patients undergoing bariatric surgery. For instance, the SOS study showed that suicide and non-fatal self-harm events were greater in the surgery group than in the matched controls. A separate analysis from the Utah long-term study also revealed that suicide and non-fatal self-harm events were more frequent after gastric bypass compared to the intensive lifestyle group. The authors concluded that while bariatric surgery, particularly gastric bypass, was associated with an increased risk of suicide or self-harm, the absolute risk and numbers of patients involved do not support not offering bariatric surgery to patients who otherwise qualify. Instead, this sensitive finding strongly emphasizes the crucial need for rigorous preoperative psychiatric mental health assessment and ongoing postoperative monitoring for mental health, particularly for substance abuse. This ensures that while the physical health improves dramatically, the mental health aspects are also carefully managed throughout their journey.
Let's talk about one of the most compelling areas where bariatric surgery truly shines: its profound impact on type 2 diabetes. The STAMPEDE trial, which is just one of 11 randomized controlled trials, has incontrovertibly demonstrated the superiority of bariatric surgery over intensive medical therapy for type 2 diabetes. This isn't just an opinion. It's backed by the highest level of scientific evidence.
That's a crucial point. These trials have shown bariatric surgery to be vastly more effective in achieving sustained glycemic control, significant and durable weight loss, reduction in diabetes medications, dramatic improvement in lipid profiles, and an enhanced quality of life. You can see this graphically illustrated in Figure 48.2 in our source material, which shows the undeniable divergence in outcomes. To quantify the difference in glycemic control, metabolic surgery consistently reduced hemoglobin A1C, or HbA1c, by 2% to 3.5%, while intensive medical therapy was only able to achieve a reduction of 1% to 1.5%. That's a huge difference in blood sugar control.
And the remission rates are equally striking, showing a true reversal of the disease for many. Table 48.4 shows that a significant number of patients, ranging from 28% to 43%, undergoing laparoscopic Roux-en-Y Gastric Bypass, or LRYGB, achieved HbA1c levels less than 6.0%, essentially non-diabetic levels. This is in stark contrast to only 5% to 7% of medically treated patients, even though those medically treated patients were still receiving intensive therapy. It really highlights the transformative power of surgical intervention beyond what any medication regimen can achieve.
What's truly remarkable here is that for RYGB, the effect of the duodenal bypass on the improvement in diabetes appears to be partially unrelated to the magnitude of weight loss alone. This suggests a direct metabolic effect on hormone signaling and glucose regulation beyond just the mechanical reduction in food intake. However, it's critical to note that sustained long-term weight loss remains an essential element of the salutary effects of RYGB on type 2 diabetes, so it's a synergistic effect. Beyond diabetes, LRYGB also significantly improves other associated medical conditions of the metabolic syndrome, including hypertension and high-density lipoprotein, or HDL, cholesterol, as seen in Table 48.3. This, of course, results in a dramatically reduced incidence of cardiovascular events and deaths, fundamentally altering the patient's long-term health outlook.
That makes sense.
The evidence becomes even more powerful when we consider microvascular complications, the damage to small blood vessels that diabetes notoriously causes, leading to blindness, kidney failure, and nerve damage. Diabetic patients who undergo bariatric surgery have a significantly lower rate of incident microvascular disease, 16.9% in the surgery group versus 34.7% in the medical group. That's less than half. Breaking that down, the reduced incidence was most pronounced in nephropathy, or kidney disease, with a 59% reduction, but also significantly present in diabetic neuropathy, with a 63% reduction in nerve damage, and diabetic retinopathy, with a 45% reduction in eye damage. These are profoundly debilitating complications that surgery can help prevent.
This raises an important question, almost a call to action. How does this compelling evidence of reduced microvascular disease and improved survival lead to a direct mandate for primary care providers to actively discuss bariatric surgery with their obese diabetic patients? It seems almost negligent not to, given these profound life-altering benefits. The data truly speaks for itself, and it's incumbent upon the medical community to embrace this paradigm shift.
Couldn't agree more.
So moving on to how these surgeries actually work. When surgery was first reported to ameliorate diabetes back in 1955 after a subtotal gastrectomy, the prevailing theories for surgically induced weight loss were quite straightforward: caloric restriction and nutrient malabsorption. And while those certainly play a role, our understanding has evolved tremendously to reveal a much more complex and fascinating biological story.
That's right. While there's no question that reducing caloric intake and the resulting weight loss are responsible for much of the improvement in comorbidities after bariatric surgery, these initial concepts of restriction and malabsorption do not fully explain the profound metabolic effects we observe, particularly the rapid and durable resolution of diabetes. In fact, the mechanisms extend far beyond just the sheer magnitude of weight loss. They now include complex effects on the central nervous system's regulation of appetite and metabolism, as well as significant improvements in insulin secretion and sensitivity. Long-term weight loss, improved glucose metabolism, and other metabolic benefits clearly result from significant post-operative changes in what we call the enteroencephalic and enteroinsular endocrine axes, as summarized in Table 48.5. These axes represent the intricate communication pathways between our gut, our brain, and our pancreas.
So what does this all mean for the patient? It tells us that bariatric surgery isn't just about mechanically making your stomach smaller or absorbing fewer calories. It's about a fundamental biological recalibration of how the body processes food, how it signals hunger and satiety, and how it regulates its metabolism. It's truly a metabolic intervention, not just a weight loss one. Really understanding this is key to mastering the topic.
Exactly. Let's explore the enteroencephalic endocrine axis first, which governs satiety and hunger signals, basically, how our gut talks to our brain about when we're full or hungry. Procedures like Roux-en-Y Gastric Bypass and Laparoscopic Sleeve Gastrectomy are known to significantly increase satiety and reduce hunger. This occurs through a complex interplay between the gastrointestinal tract and the brain's regulatory centers, primarily the hypothalamus. The hypothalamus, which is a key area involved in appetite regulation, uses a complex system of anorexic appetite suppressing and orexigenic appetite stimulating neuronal signaling. Neuropeptide Y, or NPY, is the dominant hormonal signal regulating energy intake, and its release is modulated by hormones secreted by GI cells, such as ghrelin and peptide YY, or PYY. Let's specifically look at ghrelin. It's secreted by PD-1 cells in the fundus of the stomach, and its levels typically increase significantly before a meal, creating that sensation of hunger and diminishing rapidly post-meal. Ghrelin activates receptors in the arcuate nucleus and lateral hypothalamus, stimulating the synthesis of NPY and other proteins, thus creating an orexigenic signal, making you feel hungry. Think of ghrelin as your stomach's empty signal. It screams hunger.
We mentioned that earlier, the hunger hormone.
That's the one. Now, while some studies on ghrelin levels after RYGB have been contradictory, particularly concerning fasting levels, a recent cross-sectional study by Spain and colleagues provided more definitive data. This study showed that postprandial, after meal, ghrelin levels were significantly lower after LSG compared with RYGB in controls. Moreover, total ghrelin was significantly lower after RYGB compared with controls. This provides strong evidence that the anatomic changes from bariatric surgery truly reduce the postprandial secretion of ghrelin, thereby dramatically reducing hunger signals. This is a critical biological mechanism explaining why patients feel less hungry and more satisfied. Then there's peptide YY, or PYY. This hormone is secreted by L cells found throughout the small and large intestines in response to nutrients. PYY exerts an anorexigenic or appetite-suppressing effect on NPY neurons, so it's the I'm full signal. The same study by Spain and colleagues demonstrated that postprandial PYY levels are significantly affected by bariatric surgery. RYGB patients showed significantly higher PYY peak and area under the curve than both LSG and matched controls, while LSG patients showed no significant difference from controls in PYY. This highlights a procedure-specific impact on satiety hormones, with RYGB having a particularly strong effect on this fullness signal.
Now let's turn our attention to the enteroinsular endocrine axis, which is crucial for insulin and metabolic control. The remarkable remission or amelioration of type 2 diabetes mellitus is considered one of the major life-changing benefits after bariatric surgery. This involves improved insulin action, better beta cell function in the pancreas, and the powerful modulative effect of these same gut hormones.
Among these hormones, glucagon-like peptide 1, or GLP-1, appears to be the major player. GLP-1 is released by L cells in the distal gastrointestinal tract, and its levels increase rapidly in response to the presence of nutrients in the lumen of the distal or hindgut intestines. In obese subjects, there's a characteristic delay in the postprandial release of GLP-1 and overall significantly reduced circulating levels of the peptide. Physiologically, GLP-1 has many critical functions. It powerfully stimulates insulin secretion by the pancreas, increases the insulin sensitivity of pancreatic cells, and inhibits glucagon secretion, all crucial for glucose control. Many studies consistently show that GLP-1 is a major driver of insulin secretion after bariatric surgery. It's been found to be consistently elevated both in peak and postprandial area under the curve in response to both RYGB and LSG, with a significantly higher magnitude in RYGB.
And this effect isn't just from the weight loss itself, right?
Crucially, no. This rapid and dramatic effect on postprandial GLP-1 secretion is not observed in subjects who achieve an equivalent degree of weight loss through caloric restriction alone. This provides further compelling evidence that bariatric surgery has a significant direct metabolic effect that is independent of mere weight loss. It's a fundamental recalibration of the body's metabolic machinery, a powerful biohack that changes how the body handles glucose and satiety signals, allowing it to function more effectively, almost as if it's been reset.
Okay, so now that we understand the why and the how biologically, let's talk about the practical side. Who qualifies for bariatric surgery and the comprehensive evaluation process involved? Setting the stage for success, as the source puts it. Patient selection is based on currently accepted guidelines from leading organizations like the NIH and the American Heart Association, American College of Cardiology, and the Obesity Society. Generally, patients must have a BMI greater than 40 kilograms problem without any associated medical comorbidities, or a BMI greater than 35 kilograms problem with at least one associated medical problem that's worsened by obesity, like type 2 diabetes or hypertension. Beyond the numbers, they must also have a documented history of failing prior dietary and behavioral therapies, showing that non-surgical approaches haven't been effective. And there are crucial non-physical criteria: psychiatric stability, a motivated attitude, and the ability to truly comprehend the nature of the operation and the significant lifelong changes it demands in eating behavior and lifestyle. Finally, their existing medical problems must not preclude probable survival from the surgery, ensuring the benefits outweigh the risks.
It's important to underscore that an inability to fulfill these criteria is considered a contraindication to bariatric surgery. These guidelines are there to ensure patient safety and optimize outcomes, not to create arbitrary hurdles. They reflect a careful balancing act of risks versus benefits for each individual.
One criterion not explicitly listed in those medical guidelines, but which is unfortunately often a significant issue for severely obese patients, is insurance coverage for the operation. Despite overwhelming evidence of its effectiveness, the only long-term treatment modality for severe obesity, the Affordable Care Act, or ACA, mandates screening and counseling for obesity, but does not mandate coverage for bariatric surgery in federal marketplace plans. This is a perplexing gap, isn't it? Especially given the ACA's intent to prevent bias against pre-existing conditions and provide comprehensive care.
It really is. It puts a significant financial barrier in front of many who could benefit. It truly is a disconnect between evidence and policy. However, there have been some positive policy shifts. In 2006, the Centers for Medicare and Medicaid Services, CMS, which sets Medicare guidelines, required that only surgeons and hospitals designated as centers of excellence could perform bariatric surgery. This was partly driven by concerns about historically higher morbidity and mortality rates. But by 2013, CMS actually removed these requirements, a clear reflection of the significant and demonstrable improvements in bariatric surgery outcomes nationwide. Today, over 88% of bariatric procedures are performed at metabolic and bariatric accredited and quality improvement programs, or MBSA QIP, which means they adhere to stringent quality standards and continuous outcome monitoring. This accreditation provides a crucial layer of safety and quality assurance for patients.
And medical societies are increasingly catching up to the powerful evidence. The American Diabetes Association, for example, now recommends metabolic surgery as an option to treat type 2 diabetes in appropriate surgical candidates with a BMI greater than 40 kg/rs, or even greater than 37.5 kg/rs in Asian Americans who haven't achieved durable weight loss and improvement in comorbidities with reasonable non-surgical methods. This signals a growing recognition of surgery not just as a last resort, but as a primary, highly effective treatment option for this specific patient population.
While accreditation and structured quality programs are undoubtedly vital for improved outcomes, our source points to a critical element that stands above even institutional excellence: the technical skill of the individual surgeon. This has been highly correlated with significantly fewer complications, readmissions, reoperations, and emergency department visits. It underscores that while the system is important, the human factor of surgical expertise is paramount.
That's fascinating because it suggests that even within centers of excellence, where you'd expect uniformly high standards, there can still be considerable variation in serious complications within 30 days of the procedure. The source suggests these differences couldn't be fully explained by factors like hospital volume, patient mix, or procedure type. This indicates that the skill of the individual surgeon and consistent adherence to established surgical pathways are truly paramount. It's a testament to the art as well as the science of surgery.
Absolutely. The takeaway is clear. Surgeons must not only achieve technical proficiency themselves, but also actively engage the entire operative and hospital team to consistently achieve excellent outcomes for these complex patients. It's a true team sport with the surgeon as the conductor, ensuring every member is performing at their peak to ensure patient safety and success. In terms of understanding surgical risks, it's vital to know that bariatric operative mortality has declined to remarkably low levels worldwide. For example, in France, data from over 6,000 laparoscopic adjustable gastric banding operations showed zero mortality in 2012. Similarly, laparoscopic Roux-en-Y Gastric Bypass mortality decreased threefold, from 0.3% to just 0.11% between 2008 and 2012. These figures are now comparable to many routine operations. However, certain factors are associated with an increased operative mortality. In France, these included male sex, age over 50, a BMI under 50 km, which might seem counterintuitive but often indicates a different risk profile, possibly due to higher frailty or other underlying conditions and the presence of type 2 diabetes. Additionally, there was a clear relationship between higher hospital volume and decreased operative mortality, reinforcing the benefits of specialized centers.
It's important to understand that medical contraindications to bariatric surgery are generally considered relative, meaning they're evaluated on a case-by-case basis, weighing individual risks and benefits. However, patients with end-stage organ dysfunction, particularly of the heart or lungs, are unlikely to gain the longevity or health benefits, making surgery generally not advisable for them. There are a couple of absolute contraindications. Patients who are unable to ambulate, as their level of debility precludes effective recovery during the rapid weight loss phase after surgery, and individuals with Prader-Willi syndrome, because no surgical therapy has been found to affect their constant, insatiable need to eat, rendering bariatric surgery ineffective for them.
Specific to laparoscopic adjustable gastric banding, or LAGB, contraindications also include cirrhosis, portal hypertension, autoimmune connective tissue disorders, chronic inflammatory conditions like inflammatory bowel disease, and the need for chronic administration of steroids. For patients who weigh more than 500 pounds, there's an increased risk for mortality and more complications. Practical limitations become a significant factor as well. Many diagnostic tools like CT scanners, operating room tables, and even blood pressure cuffs have weight limits. Moving and lifting equipment and teams becomes extraordinarily difficult. In such cases, it's common practice to require patients to first lose weight non-operatively down to a safer level before surgery can be considered, making the procedure more feasible and less risky.
Age can be a controversial contraindication, particularly when it comes to adolescents. So what are the special considerations for this younger demographic, and is there truly an upper age limit for bariatric surgery?
For adolescents, most pediatric and bariatric surgeons recommend performing the operation after the major growth spurt, typically in the mid to late teens, to allow for increased maturity and understanding of the lifelong commitment. The Teen Longitudinal Assessment of Bariatric Surgery, or Teen LAPS, study demonstrated that severely obese teens under 19 years old, many with multiple comorbidities, could safely undergo LRYGB, LSG, or LSG with no mortality and a favorable short-term complication profile. What's truly remarkable is that 3-year follow-up after LRYGB or LSG in Teen Lab showed excellent and sustained weight loss and an astounding 95% resolution of type 2 diabetes in patients who had it at baseline.
95%, that's incredible.
It is. This figure is significantly higher than the 50% to 70% remission rate seen in adult bariatric surgery patients. The hypothesis is that adults accumulate pounds years that are less reversible than in the adolescent population. For older patients, generally those over 65-70, evaluations focus on their physiologic age and potential for longevity rather than just chronological age. The duration and degree of obesity, along with the number of comorbid medical problems, are the most important factors in evaluating an older patient, as more severe or longer-term obesity tends to lower the potential benefit. It's about overall health, not just years.
So given all these considerations, what does a comprehensive preoperative assessment and preparation involve for these patients? It really emphasizes a multidisciplinary team approach.
Indeed, a team approach is absolutely required for optimal care, as it ensures all facets of the patient's health and well-being are addressed. Our source outlines it clearly in box 48.3, encompassing the surgeon, assisting surgeon, nutritionist, anesthesiologist or staff, nurse care coordinator, educator, psychiatrist, psychologist, the patient's primary care physician, and various medical specialists as indicated for cardiac, pulmonary, gastrointestinal, endocrine, musculoskeletal, and neurologic conditions. This team works in concert. The general steps, summarized in box 48.4, begin even before the first clinic visit, requiring documented medically supervised diets, a PCP referral, and reading a comprehensive brochure or attending a seminar. The initial clinic visit involves group presentations on the procedure and nutrition, followed by individual assessments and counseling with the surgeon and nutritionist, along with screening blood tests. Subsequent steps include a full psychological assessment, medical specialist evaluations, and insurance approval. Finally, before surgery, patients undergo screening, endoscopy, or ultrasound, and possibly an arterial blood gas analysis. The journey culminates in final counseling sessions with the surgeon and nurse educator and a preoperative evaluation by the anesthesiologist. It's a thorough, sequential process designed for safety and success.
And minimizing risks during surgery is key too. What about prophylaxis?
Yes, prophylaxis is crucial. Preoperative antibiotics, typically a first-generation cephalosporin in a weight-appropriate dose, are administered and continued for less than 24 hours to prevent surgical site infections. Bariatric surgery patients are at moderate to high risk for venous thromboembolism, or VTE, which includes deep vein thrombosis and pulmonary embolism. Therefore, both mechanical prophylaxis, like early ambulation and sequential compression devices, SCDs, and chemoprophylaxis are standard. The Michigan Bariatric Surgery Collaborative, MBSC, found that preoperative and postoperative use of low molecular weight heparin was associated with significantly lower rates of VTE compared to unfractionated heparin. For high-risk patients, for example, those with a history of DVT, pulmonary hypertension, or hypoventilation syndrome of obesity, low molecular weight heparin is administered twice daily for a full 2-week course. The use of prophylactic vena cava filters is generally reserved for extremely high-risk individuals in whom the VTE risks clearly outweigh the potential filter-related complications, and only in combination with chemical and mechanical prophylaxis. Every measure is taken to reduce these serious but preventable risks.
Beyond general preparation, a detailed evaluation of specific comorbid conditions is critically important for tailoring patient assessment and maximizing safety and outcomes. This is where the multidisciplinary team truly shines, right? Getting into the specifics for each patient.
Absolutely. For cardiovascular evaluation, we look for a history of chest pain and perform a functional assessment of activity related to cardiac function. Stress testing is indicated when necessary to uncover hidden heart issues. It's important to note that Swan-Ganz catheters, which were once used to measure heart pressures, are rarely resorted to now, as central venous and pulmonary hypertension are routinely present in these patients and shouldn't be misinterpreted as volume overload, which can lead to inappropriate treatment. Obstructive sleep apnea, OSA, is highly prevalent, affecting anywhere from 35% to 94% of morbidly obese patients, with most studies showing a prevalence greater than 60%. A clinical history of falling asleep during the day, chronic tiredness, loud snoring, or witnessed apnea strongly suggests the condition and warrants a preoperative sleep study. If OSA is diagnosed, the use of continuous or bilevel positive airway pressure apparatus postoperatively is crucial to prevent dangerous hypoxic episodes, especially since narcotic pain medications and postoperative fluid shifts can enhance these effects and affect hemodynamic stability.
What about breathing issues beyond sleep apnea?
Well, reactive asthma is another common but under-recognized problem in this population, though it generally requires less rigorous preoperative preparation than sleep apnea and carries less danger during surgery. Hypoventilation syndrome of obesity, also known as Pickwickian syndrome, should be suspected in superobese patients, those with a BMI greater than 60 kilometers at opponus. These individuals may have plethoric faces, appear cyanotic, and clearly exhibit difficulty with normal breathing efforts at baseline or with mild exertion. Arterial blood gas analysis would show high PaCO2, low PaO2, and an elevated hematocrit alongside greatly elevated pulmonary artery pressure. These patients carry significantly increased cardiopulmonary morbidity and mortality risks and require substantial preoperative weight loss and optimization of their cardiopulmonary physiology before any surgical procedure can be safely considered.
And other systems. Kidney function, bones and joints.
For renal function, serum creatinine is an excellent preoperative screening test, given the increased incidence of hypertension and diabetes often associated with renal disease in this population. It gives a quick snapshot of baseline kidney health. Musculoskeletal conditions, particularly arthritis and degenerative joint disease, are the most common group of comorbid diseases, present in over 50% of patients. While bariatric surgery cannot reverse pre-existing structural damage, significant weight loss often alleviates or even reverses chronic pain and disability, allowing patients to regain mobility. Furthermore, it makes subsequent joint replacement surgeries, like knee and hip replacements, much safer and more effective, reducing complications and improving recovery.
That's a huge quality of life improvement.
Definitely. Metabolic problems like hyperlipidemia, hypercholesterolemia, and type 2 diabetes mellitus are extremely common, affecting 20% to 30% of severely obese patients undergoing bariatric surgery. Preoperative control of diabetes is absolutely essential to reduce the incidence of perioperative morbidity, ensuring smoother and safer surgery. The skin and integumentary system must be carefully examined for fungal infections and venostasis changes, which are associated with a greatly increased incidence of postoperative deep vein thrombosis. Ventral hernias are often present, but it's common practice to postpone their repair until after significant weight loss, often at the time of an abdominoplasty, which allows for robust reinforcement with prosthetic mesh and a much more effective outcome.
And gastrointestinal issues. We mentioned GERD and gallstones earlier.
Right. Within the gastrointestinal system, cholelithiasis, or gallstones, is the most prevalent condition. If gallstones are present, most surgeons agree that a cholecystectomy should be performed simultaneously with bariatric surgery. For malabsorptive operations, gallstone or sludge formation is so frequent at approximately 30% incidence after gastric bypass that prophylactic cholecystectomy is a standard part of these procedures to prevent future complications. However, for restrictive operations, screening ultrasound is recommended. Ursodeoxycholic acid, a medication given at 300 milligrams twice daily for 6 months postoperatively, reduces the incidence of gallstone formation to a mere 3%. Our current recommendations are simultaneous cholecystectomy if gallstones are present, and ursodiol therapy for 6 months if the gallbladder is normal, ensuring a proactive approach. Gastroesophageal reflux disease, or GERD, is also common in severely obese patients due to increased abdominal pressure and a shortened lower esophageal sphincter, making reflux worse. Preoperative upper endoscopy is indicated in all patients with GERD symptoms to detect conditions like Barrett's esophagus, which is a precancerous change, hiatal hernias, and to evaluate the lower part of the stomach, especially in patients undergoing RYGB for optimal surgical planning. Finally, non-alcoholic steatotic hepatitis, or NASH, presents a potential challenge during surgery due to the often enlarged left lobe of the liver, which can inhibit laparoscopic access. Patients with known enlarged fatty livers may benefit from calorie and carbohydrate restriction for 5 to 10 days preoperatively to shrink the liver. While bariatric surgery itself is profoundly beneficial for NASH and improves prognosis with weight loss, NASH is not a contraindication unless there is cirrhosis, portal hypertension, or hepatocellular decompensation. A liver biopsy should be performed if the liver appears abnormal intraoperatively to assess the extent of damage.
Beyond the clinical assessments and medical evaluations, there are also very practical adjustments needed for bariatric care, requiring special equipment tailored to the size of morbidly obese patients, from the initial clinic visit all the way to the operating room. This often overlooked aspect is crucial for patient comfort and safety.
Absolutely. In the clinic, the waiting area needs comfortable benches with backs, not standard chairs, and extra-wide doorways and bathrooms. Toilets must be floor-mounted for stability. An 800-pound capacity scale is necessary for accurate weight tracking, and impedance scales are useful for monitoring fat versus muscle loss. Patients need large-sized gowns, wide, stable examining tables, and wide blood pressure cuffs. A large room with appropriate seating is also essential for patient group education sessions, fostering a supportive community environment.
And in the OR itself,
In the operating room, a hydraulically operated OR table that can accommodate up to 800 pounds is crucial, along with side attachments to widen the table. Foam cushioning, extra-large sequential compression device stockings, wide and secure padded straps for the abdomen and legs, and a footboard are all essential for safely securing the patient, especially in a steep reverse Trendelenburg position, which is often needed. For laparoscopic procedures, high-quality video telescopic equipment with 2 monitors and high-flow insufflators are vital to maintain pneumoperitoneum. Finally, specialized extra-long instruments like staplers, atraumatic graspers, trocars, and an ultrasonic scalpel are necessary to navigate the anatomy. A fixed retractor device secured to the OR table for clamping and holding the liver retractor is essential, as a large, thick liver can be one of the most difficult technical challenges. Sometimes even 2 retractors may be necessary for a very large liver. These aren't just luxuries, they're essential safety and efficacy tools.
let's transition now to the operative procedures themselves. It's not about learning every minute detail of the surgery, perhaps, but really understanding the fundamental principles, how they work, and what makes each procedure unique. Let's start with Laparoscopic Adjustable Gastric Banding, or LAGB. This procedure has some distinct advantages, namely its individualized adjustability and a markedly lower initial operative morbidity and mortality compared to other bariatric surgeries.
The core principle of LAGB involves placing an adjustable inflatable band around the upper part of the stomach. This creates a small, new stomach pouch above the band and a much smaller opening to the rest of the stomach below. The beauty of this approach is its adjustability. The band is connected to an access port placed under the skin, allowing saline to be added or removed. This can be done postoperatively in a clinic setting to tighten or loosen the band's restriction, fine-tuning the rate of weight loss for each individual patient. This allows for a customized approach to restriction, which was a unique advantage.
Next, let's explore Roux-en-Y Gastric Bypass, or RYGB, which has become one of the most commonly performed bariatric operations in the United States and is often considered the gold standard. It famously replaced older techniques that used a loop of jejunum due to problems with bile reflux.
Indeed. The RYGB technique incorporates several essential principles for optimal results, as outlined in Table 48.6. The goal is to create a very small stomach pouch, typically 15 to 20 millio, which is roughly the size of an egg. This small pouch dramatically restricts food intake. Then, a section of the small intestine called the jejunum is divided. One end is connected directly to the new small stomach pouch, the gastrojejunostomy, bypassing a significant portion of the stomach and the upper part of the small intestine, duodenum and proximal jejunum. The other end of the divided jejunum is reconnected further down the digestive tract, the jejunojejunostomy, to allow digestive fluids from the bypass section to eventually meet the food.
So it reroutes the plumbing, essentially.
Exactly. This rerouting means food bypasses a large part of the stomach and the first section of the small intestine, which is where much of the initial digestion and absorption, particularly of iron and some vitamins, takes place. This contributes to both restriction and malabsorption. Key principles include ensuring the pouch is truly small, meticulously closing any internal gaps created by the rerouting of the intestine to prevent internal hernias, and using a specific length of the bypassed bowel, often 75 centimeters or more, to optimize metabolic changes and weight loss. For patients with very high BMIs, even longer lengths of bypassed bowel might be used. This combination of restriction and bypass of nutrient absorption areas, along with the significant hormonal changes, is what makes RYGB so effective.
Let's move on to Biliopancreatic Diversion, or BPD, a procedure primarily based on malabsorption, though it also includes a restrictive component. It's a powerful operation, but also one of the most complex.
Yes, it is. The anatomical configuration of BPD is quite unique and aims to drastically reduce nutrient absorption. It begins with a significant reduction in stomach size, often a discal hemigastrectomy, which removes a large part of the stomach. The intestinal tract is then reconstructed to leave only a very short common channel, typically just 50 centimeters of the distal terminal ileum for the absorption of fat and protein. The alimentary tract beyond the remaining stomach is rearranged so that food travels directly to the very end of the small intestine. This means food mixes with digestive enzymes and bile only in that last short 50-centimeter segment. This dramatically limits the body's ability to absorb calories, fats, and proteins, leading to profound weight loss, but also significant nutritional challenges.
Now, a modification of BPD, known as the Duodenal Switch, or DS, was developed to help lessen the high incidence of marginal ulcers seen with BPD, while still maintaining a similar powerful weight loss mechanism.
The configuration of DS involves a slightly longer common channel, typically 100 centimeters, and the entire alimentary tract measures 250 centimeters. The key difference from the traditional BPD, however, is that a laparoscopic sleeve gastrectomy, or LSG, of the greater curvature is performed first. This crucial modification creates a gastric sleeve by removing about 80% of the stomach, but importantly, it preserves the pylorus, the valve that controls the flow of food from the stomach to the small intestine. This preservation is what helps reduce the risk of marginal ulcers and dumping syndrome compared to traditional BPD.
So the sleeve is part of the DS.
Exactly. Follow the sleeve gastrectomy, the duodenum, the very first part of the small intestine, is divided just beyond the pylorus. Then the small intestine is rearranged. The end of the small intestine is connected to the duodenum just after the pylorus, allowing food to enter the digestive tract there. And the biliopancreatic limb, carrying digestive juices, is connected much further down. This approach allows for a two-stage DS approach, especially for extremely high BMI patients who might be at high operative risk. In such cases, the LSG alone can be performed as the first stage. If intraoperative instability occurs, the operation can be safely discontinued, reducing the overall mortality risk, with the second, more complex stage performed later when the patient is healthier after initial weight loss. This strategic two-stage option makes it safer for the most challenging cases.
Finally, let's talk about laparoscopic sleeve gastrectomy, or LSG, which has truly emerged as a rising star in bariatric surgery. It even received its own current procedural terminology, or CPT, code in 2010. Its popularity has seen a precipitous rise, going from just under 1% of all bariatric procedures in 2008 to an astounding 60% by 2017, as shown in Table 48.7. That's a huge shift.
It really is. The advantages of LSG are numerous and explain its rapid rise. It's technically simpler than RYGB. It involves removing about 80% of the stomach, creating a tube-shaped sleeve, but importantly, it preserves the pylorus, which controls stomach emptying. This preservation avoids the complication of dumping syndrome, which can occur with RYGB. Metabolically, it significantly reduces ghrelin levels, the hunger hormone, contributing to a feeling of satiety and reduced appetite. There's no need for serial adjustments, unlike LAGB, and it reduces the incidence of internal hernias, a risk seen after RYGB, because it doesn't involve rerouting the small intestine. The procedure essentially works by reducing stomach volume and altering hormonal signals, leading to weight loss and metabolic improvements.
Now, there's been some controversies surrounding LSG, specifically about staple line reinforcement to prevent bleeding or leaks, as highlighted in Table 48.8. Some studies conflict on its necessity, and some, like the Michigan Bariatric Surgery Collaborative, suggest that surgical skill and experience are actually more paramount than specific reinforcement techniques.
That's an ongoing debate, yes. The technique itself involves carefully dividing the stomach along its greater curvature, leaving a narrow tube or sleeve, while meticulously preserving the blood supply along the lesser curve. Avoiding twists or kinks is also critical.
Okay, let's turn our attention now to the recovery journey, beginning with postoperative management for laparoscopic adjustable gastric banding, or LAGB. Patients typically experience a remarkably rapid recovery. The operation itself can take as little as an hour in experienced hands, and an overnight hospital stay is the norm, with some reports even showing same-day discharge.
Regarding band management, the band is initially placed without any saline to distend it, allowing the stomach to heal. Saline is then added in small incremental amounts postoperatively in a clinic visit to achieve a desired weight loss of 1 to 2 kilograms per week. If there's excess weight loss, a small amount of saline may be removed, while inadequate weight loss indicates the need for more saline to increase restriction. A key advantage of LAGB is the low incidence of nutritional deficiencies, as there's no disruption to the normal gastrointestinal tract. However, specific complications can arise, which we'll discuss later.
Now let's look at the postoperative management for the other major procedures: Roux-en-Y Gastric Bypass, Biliopancreatic Diversion, Duodenal Switch, and Laparoscopic Sleeve Gastrectomy. The foundation for excellent outcomes for these operations truly lies in meticulous patient selection, thorough preoperative preparation, technically well-performed operations, and perhaps most importantly, attentive postoperative care. It's a holistic approach to recovery.
You've hit on a critical point. The most dreaded complication after bariatric surgery across these procedures is a leak from the gastrointestinal tract. What makes this particularly challenging in severely obese patients is that the signs can be incredibly subtle. Tachycardia, meaning an elevated heart rate, often accompanied by tachypnea or rapid breathing or even just agitation, may be the only initial manifestation of this severe intra-abdominal problem. Unlike patients with a normal body habitus, a severely obese patient may not develop a fever or overt signs of peritonitis due to their altered inflammatory response. Therefore, a high index of suspicion for a leak is absolutely critical if a postoperative patient shows sustained tachycardia, any fever, or increased pain. If a leak is suspected, a CT scan with oral contrast, or if necessary, even diagnostic laparoscopy, may be needed to establish the diagnosis quickly before overwhelming sepsis sets in. Rapid diagnosis and intervention are life-saving.
In terms of fluid management, patients undergoing laparoscopic surgery typically experience much less third space fluid loss and operative blood loss compared to open surgery. This allows for a more conservative approach to IV fluids, usually managed with about 4 mg/h of intravenous fluids. Intraoperative oliguria, meaning low urine output, is normal due to the nil peritoneum and generally improves in the recovery room. However, caution is needed with patients who have been taking diuretics chronically. Surgeons must ensure adequate volume resuscitation before administering diuretics. Higher than expected fluid requirements, combined with persistent low urine output and sustained tachycardia, are a constellation of postoperative findings that strongly suggest an intra-abdominal problem, necessitating immediate investigation.
Adequate pain control is also essential for a smooth recovery. One of the benefits of the laparoscopic approach is that it generally leads to decreased narcotic requirements. Patient-controlled analgesia, or PCA, pumps are often helpful, allowing patients to manage their own pain. The use of non-narcotic intravenous pain medications and local anesthetics injected into the incisions at the time of surgery has been extremely beneficial in reducing postoperative pain, contributing to earlier mobility and overall comfort.
The Achilles heel of LSG specifically appears to be a leak along the long gastric staple line. While a leak after gastric bypass is one of the most feared complications, leaks after LSG tend to appear a bit later, typically between 1 and 4 weeks postoperatively, and often present as an indolent infection or abscess rather than immediate frank shock.
There's actually conflicting evidence regarding the exact leak rate, with some older series showing LSG leaks being more common than in LRYGB. However, the most recent data indicates that the leak rate is decreasing over time and is becoming less common in LSG than in LRYGB, reflecting improved surgical techniques and experience. These leaks are most likely to be located in the proximal third of the stomach. Management typically involves adequate drainage, either through CT-guided percutaneous catheter placement or surgical approaches, along with total parenteral nutrition, meaning no oral intake, and antibiotics to control infection. In most cases, endoscopic closure of the fistula and endoscopic stenting to prevent ongoing contamination of the peritoneal cavity have proven effective. The causes of leaks are multifactorial. Early leaks occurring within 2 days are often related to stapler misfires or tissue trauma, while late leaks are typically related to ischemia and high intragastric pressure, particularly when there's distal narrowing, often at the incisura angularis.
What's fascinating here is the evidence for prevention of these leaks. The Michigan Bariatric Surgery Collaborative, or MBSC, demonstrated that leak rates fell significantly over a 5-year period. This decline was strongly associated with increased case volume, meaning surgeons who performed more than 43 cases per year had a significantly lower leak rate. Oversewing the staple line was also associated with decreased rates. This really reinforces the idea that surgical skill and increasing experience directly reduce postoperative complications, proving that consistent practice and refinement lead to safer outcomes. Exactly. And modern care pathways, including enhanced recovery after surgery or ERAS protocols, have been widely implemented in bariatric surgery, fundamentally changing the recovery experience. These emphasize non-narcotic multimodality pain control, cautious limitation of intravenous fluids to prevent overload, and crucially, early ambulation, getting patients up and moving quickly after surgery. For patients undergoing LSG, one-night hospitalization and discharge on a bariatric full liquid diet are now routine, allowing for a much faster return to home and recovery in a familiar environment.
Okay, so let's zoom out and look at the bigger picture of bariatric surgery results. Across the world, there have been significant improvements over time, with declining operative mortality, shorter hospital stays, and reduced overall postoperative morbidity. It's truly a testament to advancements in surgical science and patient care.
The figures are quite striking. Operative mortality for laparoscopic adjustable gastric banding is essentially nil, and for laparoscopic Roux-en-Y Gastric Bypass, it has fallen to a remarkable 0.1% to 0.2%. These rates are now comparable to many other common operative procedures, such as laparoscopic cholecystectomy or gallbladder removal or joint replacement surgery. This highlights the incredible safety profile achieved. Moreover, large series reviewing outcomes across various countries and healthcare systems consistently show significant reductions in a wide array of comorbidities, including diabetes, hypertension, dyslipidemia, sleep apnea, asthma, arthritis, and gastroesophageal reflux disease. Data from the United Kingdom, for example, even shows a doubled ability for patients to climb 3 flights of stairs and a halved incidence of diabetes-related hyperglycemia, illustrating the profound improvement in daily function.
And crucially, beyond just treating disease, studies increasingly show that bariatric surgery not only improves physical health, but also significantly enhances weight-related quality of life and overall physical health-related quality of life. Patients report feeling better, moving more freely, and having a higher overall sense of well-being. Now let's talk about the results of laparoscopic adjustable gastric banding, or LAGB, which has truly been a declining star in the bariatric surgery landscape. It saw a rapid increase in popularity in the early 2000s, peaked around 2011, but by 2017 it constituted only 2.8% of bariatric procedures, as indicated in Table 48.7. Its initial appeal was largely due to its technical simplicity and a dramatically lower early morbidity and mortality rate compared to Roux-en-Y Gastric Bypass, which at the time had higher complication rates. Initial results for LAGB were often reported as excellent, with modest weight loss and very minimal early morbidity or mortality. Indeed, some select centers reported no 30-day mortality and reasonable weight loss, as shown in Table 48.9.
However, the long-term data revealed its Achilles heel, the reason for its sharp decline in popularity. A 10-year prospective randomized trial comparing LAGB with LRYGB demonstrated significantly poorer long-term weight loss for LRYG, 27.4 kilograms versus 42.4 kilograms for LRYGB, a much higher reoperation rate, 31.4% for LRYG versus 8.1% for LRYGB, and a lower rate of comorbidity remission. The natural history of LAG was further defined by a large French national database study of 53,000 patients, which shockingly showed that 20% of bands were removed, and by 7 years, a staggering 71% of patients underwent revisional surgery. Many of these revisions were conversions to LSG or LRYGB due to band slippage or failure to achieve adequate weight loss. This led the authors of that French study, and indeed the authors of our chapter, to question whether LAG remains a viable procedure given its high rates of removal and complications. In fact, the chapter authors state they no longer offer LAG in their practices, a strong indication of its long-term limitations.
Moving on to Roux-en-Y Gastric Bypass, or RYGB. This procedure remains the enduring workhorse of bariatric surgery, with an established long track record of safety and efficacy, particularly in the laparoscopic era, as reflected in Table 48.10.
The excellent and sustained resolution of comorbidities after LRYGB has been consistently demonstrated in long-term studies, including for diabetes, hypertension, and dyslipidemia, as shown in Tables 48.3 and 48.9. It was commonly thought that gastric bypass was associated with higher morbidity and mortality in older individuals, and that they wouldn't benefit long-term. However, studies like Davidson and colleagues identified a reduction in long-term mortality in older patients, specifically those aged 55 to 74 years, when operated on at specialized bariatric surgery centers. More recent data from the MBSAQ-IP, analyzed by Janik et al., even showed comparable mortality between older and younger individuals for both LSG and LRYGD. These findings support considering older individuals for surgery if they meet the strict criteria, focusing on physiological health rather than chronological age.
And the laparoscopic approach itself brought improvements.
Yes, another significant advantage of the laparoscopic approach to RYGB is a marked decrease in the incidence of wound complications and incisional hernias compared to open RYGB, leading to faster recovery. Hospitalization duration has also significantly decreased, with LRYGB patients typically hospitalized for only about 2 days. Beyond weight loss, RYGB has been shown to resolve the symptoms of pseudotumor cerebri, a condition causing increased pressure around the brain, and to effectively cure persistent venous stasis ulcers. Furthermore, immediate resolution of gyroid symptoms occurs in over 90% of cases due to the creation of a very small gastric pouch and the diversion of acid away from the esophagus, providing immediate relief from chronic heartburn.
Now let's discuss the results of Biliopancreatic Diversion and Duodenal Switch, or BPDDS, which are known for their high efficacy in weight loss and comorbidity resolution, but also their high complexity and potential for serious long-term nutritional challenges. The duodenal switch is actually the most common malabsorptive procedure performed in the U.S. today.
Indeed. The outcomes for BPDDS are impressive in terms of weight loss, achieving the highest excess weight loss, or EWL, among bariatric operations at 65% to 70%, with a mean percentage weight loss of 39% to 40% at 10 years, as seen in Table 48.9. It's also highly effective in treating comorbidities, with hypertension remission rates of 81%, diabetes remission at 87.5%, excellent results for lipid disorders, and resolution of obstructive sleep apnea. Some surgeons even argue that it's superior for super-obese patients due to its powerful metabolic effect.
This raises an important question. What are the significant trade-offs for these impressive results? Because the complexity certainly comes with its own set of challenges, particularly on a patient's long-term quality of life and nutritional needs.
You're right, there are serious complications and specific daily realities to consider. BPDDS has a high incidence of specific vitamin deficiencies. For example, vitamin D deficiency in nearly 90% of patients, vitamin K in 65%, and zinc in 65%. There's also a significant risk of reoperation for correction of protein malnutrition, occurring in 4% to 10% of patients, and a high rate of reoperation for treatment of incisional hernia or bowel obstruction, affecting 37% to 42% of patients. Some argue that the incremental improvements in EWL may not justify these substantially higher long-term risks and demands on the patient.
And just day-to-day life changes too.
Yes, life after BPDDS also comes with specific daily realities. Patients typically have between 2 and 4 bowel movements per day, and excessive flatulence and foul-smelling stools are the rule, largely due to the malabsorption of starch and fat, which is the primary mechanism of weight loss. This malabsorption is also what creates deficiencies in fat-soluble vitamins like K, A, D, and E. Surgeons caring for these patients must vigilantly monitor protein levels. If protein malnutrition occurs, a reoperation to lengthen the common channel may be necessary. Patients also need to be acutely aware that simple sugars, alcohol, and short-chain triglycerides are still well absorbed, meaning overindulgence in sweets, milk products, soft drinks, alcohol, and fruit can still lead to significant weight regain. Strict lifelong compliance with daily vitamin supplements, including multivitamins, at least 2 grams of oral calcium per day, and monthly fat-soluble vitamins, DKA, is absolutely critical for life. While marginal ulcers were a distinct problem with older BPD, the DS modification addresses this by preserving the pylorus. However, its overall difficulty and potential dangers mean BPD remains the least popular bariatric operation, representing less than 1% of procedures in the U.S., highlighting the need for more long-term studies to fully justify its use as a primary procedure given the high demands it places on patients.
Moving on to the modern favorite, Laparoscopic Sleeve Gastrectomy, or LSG. We've already touched on its advantages. Technical ease, ghrelin reduction leading to satiety, no need for postoperative adjustments like with LAGB, preservation of the pylorus to avoid dumping syndrome, a reduced risk of severe malabsorption, and its apparent safety in high-risk individuals.
LSG was initially developed as a first stage for a 2-stage duodenal switch in super-obese patients with a BMI over 60 kilomonometer cars, specifically to reduce the high morbidity and mortality associated with a single-stage DS in this very high-risk population. However, the American Society for Metabolic and Bariatric Surgery, ASMBS, later concluded that LSG could also be effectively used as a standalone procedure for weight loss. Modifications to the techniques, such as using a reduced bougie size and extending the sleeve into the antrum, further solidified LSG's role as a primary bariatric procedure, making it more effective and widely applicable.
And the 5-year results for LSG are quite promising, demonstrating its effectiveness as a standalone procedure. The SAMP trial, for example, showed good weight loss, with an 18.6% reduction from baseline, and nearly a quarter of patients achieving diabetes remission, as detailed in Table 48.11. Another collective series reported a weighted mean of 58.3% excess weight loss after LSG.
When comparing LSG to LRYGB in rigorous randomized controlled trials like Sleeve Pass and SMBOSS, as summarized in Table 48.2, the results are quite close. The Sleeve Pass trial showed that LRGB had slightly more weight loss, but this difference was not statistically significant. Importantly, there was no significant difference in HbA1c levels, improvement in dyslipidemia, or quality of life improvements between the two procedures, nor in late morbidity. However, LRIGB did show a greater hypertension remission rate. The SMBOSS trial similarly found no significant difference in percentage of BMI loss, complete type 2 diabetes remission, hypertension remission, quality of life, or late complications. Overall, these studies conclude that LSG is an effective bariatric procedure that compares favorably to LRYGB at 5 years after surgery, offering a robust alternative for many patients.
Okay, now it's crucial to understand that while bariatric surgery offers profound benefits, like any major operation, it comes with risks and potential complications. Some are common to any intra-abdominal surgery, such as pulmonary embolism, but each specific bariatric procedure also carries its own unique set of complications that patients need to be aware of.
Absolutely. The good news is that advancements in surgical technique, particularly the widespread adoption of laparoscopic and robotic approaches, have significantly improved overall safety. It's now well accepted that these minimally invasive procedures are much safer than older open gastric bypass in terms of 30-day mortality, overall complication rates, surgical site infections, and pulmonary complications. The benefits of laparoscopy extend far beyond just cosmetic advantages, directly influencing postoperative complication rates, which is why it's a preferred approach for virtually every patient, including for revisional operations.
Let's specifically revisit the complications associated with laparoscopic adjustable gastric banding, or LAGB. While it boasted very low early morbidity and mortality rates, its long-term weaknesses proved to be its Achilles heel, ultimately leading to its decline.
Indeed. Beyond poor long-term weight loss and a significantly higher reoperation rate of over 30% compared to other procedures, LAGB is associated with specific long-term complications. Esophageal dilation is a high-incidence issue, with over 2/3 of patients presenting for band removal showing abnormal esophageal peristalsis. Other problems include band slip or erosion, where the band moves or gradually cuts into the stomach wall, and of course failure to lose weight adequately or weight regain. It's been observed that band removal often improves symptoms of pseudoachalasia or megaesophagus that developed as a result of the band, reinforcing the need for vigilance for patients with band-related motility disorders who might require band deflation or explantation.
Now let's dive into the specific challenges of Roux-en-Y Gastric Bypass, or RYGB, the gold standard.
For RYGB, mortality rates have generally fallen into the 0.1% to 0.3% range in large series, as seen in Table 48.14. The most common causes of death identified by the Michigan Bariatric Surgery Collaborative were sepsis, or severe infection, accounting for 33% of deaths, followed by cardiac causes at 28%, and pulmonary embolism, though its incidence has been decreasing due to improved preventative measures. Factors influencing mortality include BMI and a history of venous thromboembolism as independent predictors. While male gender was historically associated with increased risk, this is less evident in recent data due to overall safety improvements.
One of the most critical complications specific to RYGB is anastomotic leaks, which can occur at either the proximal or distal connection points. Leaks from the gastrojejunostomy, where the stomach pouch is connected to the jejunum, are more common and are generally the cause of a significant percentage of life-threatening complications and deaths. What are the current rates and contributing factors?
Recent LRYGB studies report anastomotic leak rates of 0.5% to 1.5%, significantly lower than older studies. This is a crucial metric of surgical safety. Interestingly, these investigations found no significant difference in leak rates based on the specific type of anastomosis or the stapling instrument used, suggesting that the how of the connection method is less impactful than other factors. However, they did note that the use of buttressing material intended to reinforce the staple line was more common in patients who developed leaks, although there's no conclusive study showing buttressing prevents them.
So the surgeon's skill is still paramount.
Data strongly suggests that a surgeon's operative skill significantly influences the leak rate, with the most experienced surgeons consistently recording the lowest complication rates. A study from the Michigan Bariatric Surgery Collaborative identified wide variations in complications even among surgeons within centers of excellence, highlighting that individual proficiency truly matters. And even more specifically, a study found that slow surgeons performing LRYGB, taking an average of 139 minutes, had greater odds of any complications, including VTE and prolonged length of stay, compared to fast surgeons averaging 86 minutes. This was found to be independent of other factors like volume or technique, emphasizing that surgeon-specific efficiency is an important part of quality improvement and patient safety. Pulmonary embolism, or PE, remains one of the most feared complications after any bariatric surgery, where a blood clot travels to the lungs. While its incidence is lower with laparoscopic surgery than with open gastric bypass, it still accounts for about 17% of deaths, and up to 80% of patients who die after bariatric surgery have evidence of VTE. Aggressive DVT prophylaxis, including sequential compression devices on the legs, early ambulation, and low molecular weight heparin, has successfully reduced the incidence of VTE to around 0.23% in both LSG and LRYGB, according to the latest MBSA QIP reports. This proactive approach has made a significant difference.
Beyond the most severe complications, patients can also experience more general postoperative concerns, like nausea and vomiting. While this can be a normal part of adapting to food restriction, if it's persistent, it can lead to dehydration, which must be aggressively treated with intravenous fluids. This is true for all bariatric operations, not just RYGB.
And here's a critical problem that may arise with persistent vomiting after any of the bariatric operations, and one that the surgeon must recognize and treat immediately: Wernicke's encephalopathy. This is a life-threatening neurologic deficit caused by severe thiamine vitamin B1 deficiency, and it is entirely preventable with the appropriate administration of parenteral thiamine when a patient has persistent and severe vomiting. If the neurologic symptoms become significant and treatment is delayed, they may often not be fully reversible despite thiamine therapy, underscoring the importance of prompt action.
That sounds serious.
It is. Furthermore, given the high frequency of depression in the bariatric patient population, severe postoperative depression can also develop. If unrecognized, patients may completely stop eating, which initially might seem like a good sign of restriction, but it can progress to the dangerous loss of critical visceral and musculoskeletal protein mass, which can become life-threatening. This highlights the ongoing need for mental health support throughout the bariatric journey.
Another specific and potentially life-threatening complication that may result after RYGB is bowel obstruction. Patients who present with clinical or radiographic signs of small bowel obstruction after RYGB absolutely need a reoperation. The potential for internal hernias after this operation, where a loop of intestine gets trapped in the space created by the surgery, makes strangulation obstruction a frequent presentation.
Diagnosis is best achieved by an oral and intravenous contrast-enhanced CT scan of the abdomen, which helps visualize the bypassed stomach and small bowel that may be obstructed, or the mesenteric twist with volvulus of the Roux limb. It is imperative that these patients are promptly treated before retrograde distension of the biliopancreatic limb, and the distal part of the stomach leads to rupture of the distal gastric staple line, resulting in subsequent peritonitis. Emphasizing prevention, the closure of mesenteric defects has been shown to reduce the incidence of internal hernia-associated bowel obstruction by more than fourfold, adding only about 4 minutes to the operative time. In the anticolic LRYGB approach, only the jejunal-jejunostomy defect needs to be closed, further simplifying prevention efforts. Stenosis of the gastrojejunostomy, or narrowing at the connection site between the stomach pouch and the jejunum, may occur after RYGB, with reported incidences ranging from 2% to 14% across various series, with higher rates noted with circular staplers. This typically manifests 4 to 6 weeks post-operatively as a progressive intolerance to solid foods, and then eventually liquids, as food can't pass through easily. The good news is that it's usually successfully treated with endoscopic balloon dilation, where a small balloon is inflated to stretch the narrowed area. A reoperation is generally not required unless a marginal ulcer is also present.
Another specific complication is a marginal ulcer, which occurs after 2% to 10% of RYGB procedures. These can be partially prevented by preoperative treatment for Helicobacter pylori colonization, a common stomach bacterium. Patients with a marginal ulcer typically experience continuous, boring epigastric pain. Studies have linked larger pouch size to an increased risk of marginal ulceration, presumably because a larger pouch contains more acid-secreting parietal cells, leading to more acid exposure.
Standard treatment for marginal ulcer consists of medical therapy with proton pump inhibitors, which reduce stomach acid, and strict avoidance of non-steroidal anti-inflammatory drugs, or NSAIDs, which can worsen ulcers. Medical treatment usually resolves most marginal ulcers unless a fistula has formed to the lower part of the stomach, which creates an ongoing source of acid that exacerbates the ulcer. In such cases, surgery to divide the fistula becomes necessary to achieve healing.
And what about long-term nutritional issues?
Looking at long-term metabolic complications, iron and vitamin B12 deficiencies are the two most common after RYGB. Iron is preferentially absorbed in the duodenum and proximal jejunum, and since RYGB bypasses this maximal absorption area, iron deficiency, based on serum values, affects 15% to 40% of patients, with actual iron deficiency anemia occurring in up to 20%. This is typically treated with oral iron supplements, with the gluconate form being better absorbed in the less acidic environment. Vitamin B12 deficiency is reported in 15% to 20% of RYGB patients, though it rarely causes anemia. It results from inefficient absorption due to delayed mixing with intrinsic factor, a protein needed for B12 absorption. Therefore, deficiency can occur even with plentiful oral intake. Treatment involves preparations containing intrinsic factor or alternative routes like sublingual medication, nasal spray, or regular parenteral injections. Lifelong monitoring and supplementation are crucial.
Now let's discuss the most significant and specific long-term complications seen after Biliopancreatic Diversion and Duodenal Switch, or BPDS, which relates directly to its potent malabsorptive mechanism.
That would be protein malnutrition, which occurs in up to 12% of patients. It usually manifests within the first few months after surgery, but can appear sporadically later. In one series, over 10% of patients eventually required a reoperation either to reverse the BPD completely or to lengthen the common channel to improve absorption. Malabsorption of fat-soluble vitamins is another major problem. 2 years after BPD, vitamin D levels are significantly depressed in over 60% of patients, and vitamin A levels nearly 70%. The lack of clear clinical correlation with these levels suggests that the problem may be even more prevalent than often recognized, meaning patients can have deficiencies without obvious symptoms until severe.
So the risk is always there.
Yes, the ongoing risk of these issues means that late deaths from protein malnutrition and Wernicke encephalopathy can occur, indicating that these patients are always at risk for these problems, requiring lifelong vigilance and adherence to supplementation. While marginal ulcers were a distinct problem of the older BPD, the DS modification addresses this by preserving the pylorus, thus reducing that specific complication. However, the overall difficulty of the operation, coupled with its potential dangers and the high demands for patient compliance, has relegated BPD to being the least popular operation performed in the United States, with even the DS modification representing less than 1% of bariatric operations. Further studies are needed to fully evaluate the long-term consequences of BPD and DS to justify their widespread use as primary procedures, given the high demands it places on patients for compliance and monitoring.
Finally, let's look at the specific complications of laparoscopic sleeve gastrectomy, or LSG. This mortality rate at 0.08% to 0.12% falls between that of LRYGB and LGB, as shown in Table 48.15, making it a very safe procedure.
LSG's overall morbidity, including infections, reoperation, and VTE, is below that of LRYGB, but higher than LAGB. A significant advantage is its much lower rate of malabsorption of vitamins and nutrients compared to LRYGB or DS, making it ideally suited for patients with pre-existing vitamin disorders or those who require full absorption of life-saving medications, as highlighted in Table 48.16. This is a major benefit for many patients. Furthermore, studies of 30-day morbidity and mortality show a continuous decline in postoperative complications, strongly associated with increased surgical experience, reinforcing that safety is constantly improving.
The primary long-term morbidity for LSG is related to reoperation, predominantly for conversion to RYGB due to severe GR. This is a crucial point because the high-pressure system created by LSG can actually exacerbate reflux or cause new onset GR, which can be quite debilitating.
That's a key long-term challenge. One 10-year report did show a high incidence of significant weight regain at 21% and intractable reflux at 11%, leading to conversion to RYGB. However, it's important to note that these particular long-term results were from a group of patients who underwent LSG prior to 2006, when older techniques were used, typically with a larger bougie and without including parts of the antrum. Newer randomized trials like Sleeve Pass and SM-BOSS, which utilized smaller bougies, did not show significant weight regain requiring conversion. However, in both of those randomized trials, a significant number of patients either developed more severe GERD or developed GERD de novo and subsequently required conversion to RYGB. So while surgical technique has improved outcomes, GERD remains a relevant long-term consideration for LSG, and careful patient selection and counseling are vital.
Okay, let's unpack this next section. Reoperative surgery. What exactly defines a failed bariatric operation, and when is reoperation appropriate? It's a really critical decision point for both patient and surgeon, often fraught with emotional and physical complexities.
The absolute definition of a failed operation can be unclear, but most surgeons would agree on criteria such as inadequate weight loss, inadequate resolution of comorbidities, development of lifestyle negative side effects that significantly impair quality of life, or complications requiring intervention, like a stricture or severe metabolic complications after older procedures like a duodenal bypass. A common mistake made by non-bariatric surgeons or even general practitioners is correcting a complication without also providing for continued weight restriction, which inevitably leads to eventual weight regain and the patient seeking further surgical assistance for the original problem. The key decision for a bariatric surgeon is to determine if the original operation is still intact and anatomically appropriate for maintaining weight loss. If it's not, perhaps due to a pouch dilation or a band erosion, then reoperation is appropriate. However, if a patient has failed an anatomically intact and well-constructed bariatric operation, meaning the surgery itself is fine but the patient isn't losing weight, in our opinion, they are at high risk to fail a second or revisional bariatric operation, underscoring the importance of addressing behavioral and psychological factors.
And revisional surgery itself carries higher risks.
It's important to acknowledge that revisional surgery generally carries increased risks compared to primary bariatric surgery, including higher incidences of infection, organ ischemia, anastomotic leakage, blood transfusion requirements, and other severe intra-abdominal complications due to altered anatomy and scar tissue.
Despite those increased risks, there's encouraging data. An analysis of over 449,000 bariatric operations logged into the Bariatric Outcomes Longitudinal Database, or BOLDA, showed that only 6.3% of bariatric operations ultimately needed reoperation. A smaller subset, 4.4%, were corrective operations addressing specific complications, and 1.9% were conversions from one bariatric procedure to another, perhaps from a band to a bypass. This low percentage really highlights the overall efficacy and durability of current primary bariatric procedures, meaning that for the vast majority of patients, the first operation is the only one they'll need for long-term success.
Furthermore, these reoperations, despite their increased complexity, had a remarkably low mortality rate, ranging from 0.12% to 0.21%, and still achieved good one-year excess weight loss between 36% and 39%. The data suggests that reoperations for failure are not as common as one might think, and their clinical results and mortality rates are comparable to those of primary operations, which is quite reassuring for patients who might need a second procedure.
Beyond traditional open or laparoscopic surgery, endoscopy has become an increasingly important part of managing bariatric patients, not just for diagnostics, but also for novel interventions that are less invasive than traditional surgery.
That's right. For preoperative use, guidelines from the American Society for Gastrointestinal Endoscopy, in conjunction with the ASMBS, recommend considering endoscopy if a patient has a history of GERD. The dilemma lies with asymptomatic patients who may still have significant endoscopic findings that could impact surgery. A comprehensive review of 28 studies found that while over 90% of preoperative endoscopic findings didn't alter management, a notable 7.6% of patients had findings that either delayed or altered surgery, such as detecting a large hiatal hernia or a precancerous lesion.
This raises an important question. Does this data argue for routine preoperative endoscopy in all asymptomatic patients to avoid surprises at the time of surgery? It certainly seems to lean that way, suggesting a potentially valuable screening tool even for those without symptoms.
Intraoperative endoscopy has also become invaluable for real-time problem solving during surgery. Many surgeons now perform an intraoperative leak test by insufflating air into the submerged gastric pouch and proximal anastomosis, looking for bubbles, a clear sign of a leak. The endoscope is both diagnostic and therapeutic. If a leak is noted, it can be managed immediately with endoscopic clips or externally placed sutures under direct guidance. It also allows for control of bleeding along staple lines and a thorough assessment of the post-surgical anatomy, ensuring everything looks as intended before closing.
And after surgery.
Postoperatively, endoscopy plays an invaluable role in evaluating patients who return with abdominal complaints, experience weight regain, or develop complications after their altered anatomy. Understanding the post-surgical landscape can be challenging, especially years later, requiring recognition of common procedures like gastric bypass, vertical LSG, gastric banding, and vertical banded gastroplasty. It's like having a specialized roadmap for a complex internal landscape.
Let's focus on endoscopic management of complications, particularly leaks, which are one of the most dreaded and high mortality complications after bariatric surgery.
For leaks, one of the most commonly used interventions is the fully covered stent. This endoscopically placed stent traverses the perforation, decreasing ongoing contamination and often allowing the patient to continue oral intake while the leak heals. Studies report a high success rate, around 90%, with a typical healing period of 6 weeks. However, stent migration is a major issue, observed in as many as 8 out of 20 patients. To prevent this, methods like suturing or clipping the stent in place have been attempted, and using fluoroscopy is essential for proper placement. For LSG leaks, 2 overlapping stents are often needed due to the length of the sleeve. Other endoscopic approaches include over-the-scope clips, which are generally more effective for small holes with fresh edges or chronic leaks fistulas less than 1 centimeter, rather than acute large leaks. Endoscopic vacuum-assisted closure is also being used for large encapsulated leaks. This labor-intensive technique involves placing a vacuum sponge into the external cavity, requiring device changes every few days, but it can significantly shorten healing time compared to traditional methods. Finally, for small holes with large extraluminal cavities where external drainage is difficult, internal drainage with a double pigtail stent can be employed, sometimes coupled with an endoscopic ototomy for better drainage. These techniques offer less invasive alternatives to reoperation.
Strictures, or abnormal narrowings, can also occur after bariatric surgery, commonly at the pouch outlet after gastric bypass or at the incisura angularis after LSG. What are the endoscopic solutions for these?
For gastric bypass strictures, these are often managed with through-the-scope balloons, ranging from 5 millimeters to 20 millimeters in diameter. Multiple dilations are typically needed, with an increase of only 3 to 5 millimeters per sitting over several sessions. It's crucial to identify and address the underlying cause, such as smoking or NSAID use, to prevent recurrence. LSG strictures, most often at the incisura angularis, are also managed with endoscopic balloon dilation and stent placement. However, these methods are not always successful, often necessitating conversion to gastric bypass for definitive management, especially if the stricture is severe or recurs.
Let's talk about the reality of weight recidivism, which occurs in about 10% to 15% of patients after bariatric surgery. Endoscopic approaches are emerging as a new frontier to address this less invasively than another surgery.
The most commonly described procedure for weight recidivism after gastric bypass is endoscopic suturing for pouch outlet reduction. This uses an endoscopic suturing device to take full thickness bites, thereby decreasing the size of the gastrojejunostomy, the connection between the pouch and intestine, if it is dilated over time. A smaller anastomosis prolongs food retention within the pouch, which increases satiety and reduces food intake. It's vital to emphasize that this endoscopic procedure is always accompanied by intensive lifestyle counseling to improve dietary and exercise habits, as the procedure alone is not a magic bullet. Short-term weight loss has been shown, but long-term studies are still needed to confirm its sustained success.
Beyond addressing weight regain, there's a new category of primary endoscopic weight loss procedures emerging. These are designed for patients who fall between being overweight and having severe obesity, or for those who don't want to undergo anatomically altering surgery due to preference or risk.
The most common primary endoscopic weight loss procedures are space-filling devices, primarily gastric balloons. While the original Guerin-Edwards balloon was pulled due to migration and bowel obstruction issues, modern balloons are far more sophisticated. The Orbera balloon, for example, has been placed over 300,000 times with reasonable success. It's placed endoscopically, remains for 6 months, and is then removed endoscopically. Throughout this period and for an additional 6 months after removal, patients receive dietary and lifestyle counseling. Patients typically lose 30 to 50 pounds. A large Brazilian consensus statement based on over 40,000 cases notes reasonable success with minimal adverse events. Newer balloons, including air-filled or multiple balloon systems, are in trial, some even designed not to require endoscopy for placement or removal, making them even less invasive.
And endoscopic sleeve gastroplasty.
Yes, another promising endoscopic procedure is endoscopic sleeve gastroplasty. Here, the stomach walls are sutured together using an endoscopic suturing device to collapse the stomach, effectively emulating a surgical sleeve without cutting or removing any tissue. Short-term weight loss reported in small series has been greater than that achieved with medical therapy, though long-term controlled trials are still needed to fully evaluate its potential. Other novel procedures are being explored, such as liners that decrease absorption or reduce gastric emptying, and even magnets to create endoscopic bypasses. However, these currently have minimal data and unclear durability. It's important to conclude that while these endoscopic procedures will likely never be as effective as traditional bariatric surgery for severe obesity, they can provide a valuable bridge to surgical procedures or serve as an intervention that some patients find more acceptable for facilitating weight loss, being less invasive than major surgery. They fill an important gap in the treatment spectrum.
Okay, so if we connect this to the bigger picture, it's clear that the criteria for bariatric surgery are evolving. There's a significant debate around strict BMI cutoffs, with some arguing that they fail to identify all patients who would benefit most, perhaps even some who aren't conventionally considered morbidly obese.
This is a crucial point of controversy and a leading edge of research. For years, BMI has been the primary, almost sole, criterion for bariatric surgery eligibility. Yet remarkably, the evidence from the SOS study, that large Swedish trial, shows that BMI itself did not predict the beneficial effect of surgery on cardiovascular, diabetic, or cancer-related mortality. In other words, simply having a high BMI wasn't the best predictor of who would benefit most from surgery in terms of life-saving outcomes. On the other hand, fasting hyperinsulinemia, which is a strong reflection of insulin resistance and a marker of prediabetes or early diabetes, was predictive of positive bariatric surgery results across overall mortality, cardiovascular events, and the incidence of diabetes.
This raises an important question. If the true aim of bariatric surgery is not just weight loss, but also to reduce mortality, prevent diabetes, and reduce cardiovascular events, then Sjostrom, one of the leading researchers, suggests that preoperative insulin and glucose levels might actually be better, more precise criteria to select those patients who will truly benefit most from bariatric surgery. This would be a profound shift from a purely weight-based eligibility to a metabolically based one.
Building on that, a new and very controversial concept has emerged. Level 1 evidence, the highest standard of scientific proof, now demonstrates the efficacy of bariatric surgery, including RYGB, LSG, and even LAGB, over intensive medical therapy for type 2 diabetes in lower BMI patients who might not even meet the traditional BMI 35 or 40 criteria for surgery based on weight alone. Studies like Stampede, Acromodin, Mingrone, and Simonson have provided robust, undeniable evidence for this, challenging decades-old paradigms.
This represents an ongoing, significant shift in thinking within the medical community. While more medical societies and internists are recognizing and endorsing referrals to bariatric surgeons for their diabetic patients, it remains unclear when, or even if, insurance guidelines for bariatric surgery will universally endorse the use of surgery as a primary treatment for diabetes, or fundamentally shift to using metabolic variables rather than just BMI as primary criteria for surgery eligibility. This is a significant policy hurdle that still needs to be overcome, preventing access for many who could potentially benefit from life-changing intervention.
Absolutely, that's a major barrier.
So what a deep dive. We've journeyed through the complex and transformative field of morbid obesity and bariatric surgery. It's clear that surgical treatment for morbid obesity is no longer considered outside the mainstream of general surgery. In fact, it's now a fundamental component of surgical residency training programs and represents one of the fastest growing areas of general surgery, driven by its undeniable efficacy.
Despite vastly increased patient demand for these procedures and the clear evidence of benefit, surgeons annually operate on less than 2% of the eligible patients who would truly benefit from bariatric surgery. This highlights a significant unmet need and a gap between scientific evidence and widespread access to care.
And as we look to the future of care, while the disease process of morbid obesity is unfortunately still incompletely understood, its prevalence continues to rise worldwide, making these profound, life-altering interventions all the more critical and urgent.
If we connect this to the bigger picture, surgical therapy has unequivocally shown its power to reduce long-term mortality and achieve remarkable control of diabetes, proving consistently more effective than non-surgical options. Recent randomized clinical trials of bariatric surgery versus intensive medical treatment in obese diabetics have solidified bariatric surgery's superiority in the treatment of severe obesity, type 2 diabetes, hypertension, and dyslipidemia. The data is clear, compelling, and consistent across multiple studies. So for you, our listener, the provocative thought to carry forward is this. In a world grappling with an escalating obesity crisis, a condition deeply personal yet globally pervasive, how might we, as a society, overcome the remaining systemic barriers, be it outdated insurance policies, rigid eligibility criteria, or societal stigma, to ensure this life-changing, evidence-based treatment reaches every individual who could truly benefit, allowing them to not just live longer, but live healthier, more vibrant lives?
What a deep dive. Thank you for joining us on this exploration of morbid obesity and bariatric surgery. We hope you feel far more informed and empowered with this knowledge, really equipped to understand this complex field at a deeper level. Until next time, keep digging for those aha moments.